Now we can discuss both papers on isomerism related with other conditions and with abnormal lung veins and the abnormal pulmonary veins. Laurent, the cases you showed, the 13 cases, were the one not associated with isomerism. These are the isolated primarily.
Yes.
It means if you take the other one, you'll have 60, probably, or 160.
We put aside the isomerism on this case.
Question?
Because the problem is we like the junction with the sonographers. We spoke with Dr. Quarello. What is exciting is the junction between the prenatal diagnosis and the postnatal course of a baby and a child. This is when there is isomerism in a complex form. Okay, it's very interesting. It raises a lot of problems. It's an anatomical problem, embryological problem. It's interesting. But what la quintessence of the prenatal echo is to modify the normal course of a life-threatened baby. And this is a reason it's very important to check the pulmonary veins, because those babies are really modified in their lives and in their condition and in postnatal life when there is a prenatal diagnosis. And this is a responsibility of the sonographer, because for the obstetrician, this is normal pregnancy.
Yeah. Who is... Questions? Who is checking for the lung veins on every fetus? Wow, bravo. In our guidelines, I don't remember if it's the guidelines or if it's the consensus, we wrote that at least if the heart is normal, at least one vein connection to the atrium should be demonstrated.
I think on the consensus, we look at the veins. I mean, you can't do a fetal echo without looking at the veins and putting color and everything else. On the original guidelines for screening, we didn't mention veins as part of the basic or extended basic, but on the new one coming up, we're still debating a little bit, but it's going to come if feasible for the pulmonary veins.
But let's say I still, when I show some slides in my talks on the list of the things to see in the four-chamber view, I say yes, and at the end, the pulmonary veins connected to the left atrium. On the other hand, you see such an experienced person like Laurent Fermont with isolated abnormal lung veins in their centers. 13 cases over 20 years means almost all are not seen prenatally.
The 80% are the past 5 years.
Yeah.
It was not seen. It was outside the diagnosis of the diagnosis until 2005.
Okay, that means
now we begin to see perhaps. And Daniel Sidi said recently that 50% of the condition is diagnosed prenatally in his department. Probably there is. One now coming from Paul Bussière, who's going to be delivered in Necker, very recent. I saw 10 days ago. And this is important. And another point to point the important interest of prenatal echo we mentioned previously. Julian said that azygous continuation can be isolated, could be isolated. It's true, and it's a continuation, isolated, continuous azygous continuation. For the cardiologist, it's something not. It's probably an isomerism, but it's important for two reasons. First, there is possible of abnormal volvulus, postnatal volvulus, in case of left isomerism, of a problem of mesenteric commun, and second, there is a polysplenia, abnormal anomalies of the spleen, and susceptibility of infection. So, what could be considered? And I experienced one child with a prenatal diagnosis of continuation azygos. Okay, was okay at the birth, no problem. And at 3 or 4 years, he suffered from meningitis. So it's important for the pediatricians to know that, because from an isolated imaging from the prenatal diagnosis, it's important to say to the pediatrician there is a risk of abdominal problems, and there is a risk of infections later in the life with problem of vaccination, of meningococcus, anti-meningococcus vaccination. So it's important to make the injunction between the prenatal and general pediatricians and general pediatrics. So it's very important to follow those patients.
There's a series that was put together by one of my colleagues at the Brompton of population-based autonomous pulmonary venous drainage, which took out all the cases seen pre-postnatally, post-mortem in the UK and Sweden. And there were something like 400 plus cases. I can't remember the time period. There might have been 5 or 10 years. And of those, only about 14 were diagnosed prenatally.
14 out of 400.
Out of 400. And then she put together those 14 cases, prenatal cases. But I think some of the points that Lohan had made already, usually the mean age of diagnosis is quite late. Some of them have actually had fetal echo and were missed diagnosis, because it can be quite difficult. Disproportion is not very common. I think color helps a lot, but I would say if you're doing colors for pulmonary veins, try and split the image, because if not, you blur everything with the color and you think the pulmonary veins are going to the left atrium, and actually they're going towards the left atrium. But to see that separation, have one image with color, one without, otherwise you may easily falsely reassure yourself that you can see the pulmonary veins going to the left atrium and they're not actually going. So it is quite a difficult diagnosis, and family history as well. I think there are quite a few of them with recurrence.
And another point is, if you have a suspicion that the lung veins are not typically entering the left atrium, you can use the pulse Doppler, because in many cases the spectrum of the pulse Doppler is abnormal. It's not the typical, like the ductus venosus, the SD and a positive A. It's abnormal in the infracardiac, it's continuous. It's like a really vein, but it's the vessel just in direction of the heart. Let's say, I would suggest in these cases that you look at on 2D first, that you see if it's entering, and then you confirm with color Doppler, not routine color Doppler to see it, because if you have a little bit more gain, you see everything entering, even if there is a wall. You can overlap the wall by the color. Questions? The good news is of 14 cases out of 400 that there is still a lot of things to do, and this way we'll do a lot of courses. So now we have some, if you don't have questions, we will go with a few cases to end this afternoon session. And Edwin want to share with us some of his experience, and we'll have the comments of the...
Ça, c'est le tien, je crois, ou c'est le mien, je sais plus. Okay, just have a look on some case that I met previous year. The first one is this slide. We can see here on this slide that this is an axial plane. The back is on just there. I will take my... Here, the back, the left side, the right side, and the entire part of the thorax. What can you see? What are you suspected on this view, if it's possible to you to know? Have you some idea? You can say not, maybe, huh? Right aortic arch, it looks like, yes. It looks like probably the main pulmonary artery, the ductus arteriosus, probably the trachea just there. We can see the U shape on the main vessel, and here probably the right superior vena cava, and maybe here a left one, maybe. Then you can have a look on this sweep. Anterior, posterior, left and right, one vessel, the second one, and the third one. What do you think? Have you some idea? Double arch, yes. It is only for the beginning. Easy, yes. Just to remind that usually we are always saying that only the main pulmonary artery is the only vessel that are dividing, but in some uncommon cases, especially a double aortic arch, it's possible that the aortic arch can divide in two. Okay. How it looks, don't worry, but it's important in some instance to know this diagnosis because, for example, this situation was not very, the parents were very confident, but we can see on this slide postnatally that the two arches will compress the trachea, and this baby are at risk to have some kind of tracheomalacia. This baby was asymptomatic, and I know that according to the stress of the parents, according to the very high stress, the surgeon have to make an operation for this child. A preventive operation, maybe. The second one. Very nice case, very uncommon. What is the story? A friend of mine who's a sonographer sent me regularly, maybe every week, a lot of pictures to have advice. And for this case, he say, I make an ultrasound to a woman, and I saw this woman last year for the previous child, and for me everything is fine. And then actually I saw her, I asked her, how it was with your previous child. I say, the pregnancy was very fine, but afterwards my child was taken an emergency operation for the cardiac because it was an emergency nearly on the first week of life. What do you think about this picture? You can see it is a 4-chamber view, anterior, posterior, left side, right side. Something wrong or not, maybe, for you? You know the postnatal course of the baby, donc you are looking for something maybe, but it was missing initially. What do you think? Do you want another picture? Anomalies, pulmonary and drainage. Partial. Other picture, not very good resolution, but it is a real work. Maybe something bizarre here, maybe. You can see one vein. It looks like, with the setting of this proper machine, like this. Partial anomalies venous don't usually have acute manifestation postnatally. It doesn't look like this. Another hepatitis? No? No other ID? Yes, you're right. I just want to look on the picture that he sent me for his screening. It looks like nearly normal. And you can see that here, when I took the previous picture, it looks like this, like Dr. Fermont said previously on the previous lecture. Very uncommon situation, prenatally, but you can see the membrane here, and you can see the incomplete fusion of on the venous drainage to the left atria. Okay? Another situation, a very recent one. Anterior, posterior, left side, right side, you can divide maybe the left aortic, thoracic aorta. You can see both ventricle, both atria. We can see no disproportion. I just give to you another slide, a picture. You can't look because you're so far. Here it's around 54 centimeters per second. I use in a systematic way the use of color Doppler. And for example, this patient was referred because it was a suspicion of pulmonary stenosis. This woman was seen the previous scan at 22 weeks of gestation. This is the same sonographer. They send me the picture. I say, okay, it looks like, but there is no hurry because there is no consequences on the right ventricle. Have a look 2 weeks after, and then maybe I will have to see her. And then I saw this patient. You can see if you don't put Doppler, it's very easy to miss this situation. If you are a little bit experienced, skilled by echocardiography, you can see that the leaflet of the pulmonary aorta is not like usual. When you put Doppler, you can see in some instance some turbulence, some aliasing, and then I increase the PRF. Now is 95 centimeters per second. You can see there is no flow through the aorta, and there is a very mild central acceleration through the central part of the valve. It is a very mild form of pulmonary stenosis. We can ask question to my colleague. What is for you the schedule to this for the follow-up of this kind of patient, Ravi or Julien or Laurent? Every 2 weeks, every one month?
I'll do it 4 to 6 weeks.
4 to 6 weeks.
I mean, you've done one follow-up already.
Yes. There is no evolution in three times so far. You can see a small spot. You can see a doming of the leaflet. A small dilation post just after the...
I think it will progress because they will do what on the first scan you don't know how quickly.
Sure.
So I think usually in those cases I do the first scan within a couple of weeks, 2 weeks, just to start to see 2 or 3 weeks. And if it hasn't changed much, if all the Dopplers across the tricuspid valve are normal, there is no right ventricular hypertrophy, and then I make it 4 to 6 weeks after that.
Okay.
But it could still be moderate stenosis at birth. 25 weeks it could still require neonatal intervention.
It was only pickup because the sonographer put color Doppler. Without color Doppler, it's impossible to pick up this situation. Impossible. Nearly impossible. You can see on the free vessel view here the aliasing just there.
I think your 3 vessel view shows post-stenotic dilatation of the pulmonary artery, so just you pick that up.
Just there, yes. Okay. The next one. Anterior part, posterior part, left side, right side. This woman was referred because it was not usual, especially according to the position of the fetal heart within the thorax, and it was referred because it was a suspicion of CDH, congenital diaphragmatic hernia. What do you think about this situation? Not normal. Okay. What's the next step? Sorry? The left lung is here, and the right lung is very difficult to see. Very difficult. I don't say that there is no lung, but it's very difficult to see. I just have to turn a little bit around, but the mother was not very thin. Other picture, very interesting, especially that one. The left side, the right side, you can see just there. Have a look on the main pulmonary artery just there. Can you see one vessel here? This is ductus arteriosus, and here the right pulmonary artery, the originate right, going towards the left side, and there is no originate left towards the right side. In this situation, it's a very uncommon situation. It is a complete agenesis of the right pulmonary lungs. Okay? The baby, the counseling was a little bit cautious by the surgeon, and the child died within the first week of life. This situation, another one. Looks like free vessel and trachea view. What do you think about this? Normal is not always abnormal. It can be mild form, maybe. It is real life. What do you think about? Anterior, posterior, left side, right side, you can see the spine just there. Here is probably the main pulmonary artery, probably also the aorta, here the trachea, and here the superior vena cava. Julien said just previously that the size of the vessel usually have to decrease from the apical point of view. Just there, it is the main pulmonary artery. Usually the aorta is smaller, and then the superior vena cava. You can see that in this situation, it looks like normal, the diameter of the main pulmonary artery. It is only a subjective assessment, but when I measure it, it's completely normal, but it looks like not usual here. Sorry? It's an oblique view. It is an oblique view, but the thymus, I look at it, it was there. Here, a still picture. Have you some idea? No, there is no tricuspid regurgitation, there is no mitral regurgitation, there is no tumor, there is no cardiomyopathy. What? Marfan? I'm thinking about the Marfan especially, but the woman doesn't look like a very classical Marfan. I sent this patient to colleagues, very skilled cardiologist, and he makes ultrasound to the woman, and the woman have the same things. A small dilation of the post-valvular origin of the aortic root. You can say that it's maybe mild form of Marfan, maybe, or Loeys-Dietz syndrome. I searched such a syndrome, very asymptomatic usually, but it's possible to have a mild dilatation of the initial part. It's only to look. Can you see? Here, it is the roof, and here a small dilation without any regurgitation, without any stenosis. It is always what is possible to have in a practical way. We have to make a lot of scan to be used of mild form of maybe something. Okay, it's okay for me, Rabbi. Tu veux la zapette? Tu veux ça ou ça?
So I will see what I can show you as a case. The problem is that in most of these meetings, the cases are not for you, but for the first three people in front, always. Like yesterday. Malik, I showed the Pilou told me, oh, I still learn many things. I said, yes, me too. And then the same when Malik also said, oh, there are new things I can learn. And give me. So this case, only once in my life until now. This is why I show you that there are something you see, but you don't know if it's true what you see here. And then later on, when you ask specialists, they tell you, yeah, it's the diagnosis. So this is a patient with a left superior vena cava at 22 weeks. And as you have heard by Dario today, once I see this condition, I check first of all for isomerism. I check second if I have additional signs of chromosomal abnormalities, because even if we assume no, this isolate, but it is also found, we have found cases with Downs, with trisomy 18 mainly, and other things. We check for other organ involvements with a sign of syndromes. Sometimes you'll find associated with an absent, with a single umbilical artery plus other things. And if you think it's an isolated at 22 weeks, be careful, because some cases may appear isolated and develop into aortic coarctation despite having absolutely normal fourth chamber view, roughly normal fourth chamber view at 22 weeks. If you see the condition at 32 weeks, it's easier because you have already the relationship. Nevertheless, this was what I was checking for, and this is why she was coming back. And this is here the image of looking for the ascending aorta and for the aorta. Now, I went to this plane, and what I want to show you today is not the left superior vena cava and not the aorta, but the superior vena cava on the right side. Under normal conditions, what you'll see here is the superior vena cava and the interatrial septum with the left atrium with the foramen ovale, and you may see here in other planes the ductus venosus and the inferior vena cava entering. And there is a continuity between the superior vena cava and the interatrial septum. And if you look at on 2D, this is the image you will see. But to be honest, I never had paid attention to such a plane, because we use only if both vessels are normally connected to the left atrium, to the right atrium. Have you seen this now? Superior vena cava, continuity, interatrial septum, and foramen ovale flap with the septum secundum. In this fetus, I showed you before, there is a hole here. Conversely to the normal condition. That means there is a gap and a kind of an overriding of a superior vena cava. This condition is likely to be, an AST of sinus venosus type. I'm not knowing about this, but since we wrote a book, once you write a book, you have to be very precise. And when you say there is no case like this, we searched the literature. I read in cardiology books what is about this condition, because never paid attention, and said we never saw this. I don't know typical cases of this, but actually I was wondering that it should be seen if the relationship between the superior vena cava and the septum may be abnormal. And this is how we saw this. This is the left superior vena cava, pulmonary arteries, and by turning to get the aortic arc, I didn't get, but I saw what is here. And by using, you see here, you see on 2D that this vessel is connected to both atria. And by using color Doppler, you see that some color goes into the right and the other color Doppler goes to the left. So this is what you see. And this condition is a sinus venosus AST. Do you agree, Laurent? Laurent, do you agree?
Yes.
Think. Okay. So.
This problem that if it's remained in this circulation postnatally, this baby can be cyanotic.
The problem is that
prenatal generally it's left-right chart with the pulmonary vein abnormal anomaly of the anomaly of the
this. Yeah.
It's nice to see that flow from the superior vena cava, right superior vena cava, direct toward the left atrium.
Yeah. And
this is a condition known as the direct changing from the
can the sinus node be affected? Can the sinus node be affected? No. Okay. What I learned from this. Okay. Okay. What I learned from this case later on, that these cases are almost always associated with a partial anomalous of the lung vein of the upper right vein entering the superior vena cava. So now this case is an accidental finding. This is For me, it depends if I'm scanning at 8 o'clock, 9 o'clock in the morning after 2-3 espresso, or I'm scanning the afternoon at 5 o'clock. And this is probably an early diagnosis, because what you see here, this is the picture I put on my, stored on my system, but once I watch it again here, there is one vein here, and the other one is not seen. And my recommendation, once you have a suspicion of abnormal lung veins, that you get a longitudinal view. And this is this condition. One is entering here, and the upper one is supracardiac. It's a partial venous anomaly with one vein going up. And then what I did here, you turn to 90 degrees, and you see that the lower left inferior vein is going here into the atrium, but the upper one goes here into the dilated innominate or brachiocephalic vein. The fetus had no problem after 8 months, and this is where I got but they decided one of these days, if there is any signs of abnormality, they may be performing the operation. And another case, which is more tricky, here are both left are going into supracardiac, where the right were connected normally. You see here how this longitudinal view shows you that from the lung, the vessels go up. And these are also very difficult to diagnose, because you see here, on your first appreciation, you think it's a normal condition here. But what I didn't like, that near the atrium, I had the impression that this is something which is not connected. And if you go a little bit higher here, I had the impression that there is a left superior vena cava here, but it is not in the left atrium. And by using color, I could see that the veins are confluent here. It means you don't see here vein, but if you go a little bit higher, you see that there is this structure here, and it was also under control. And she came back with the next pregnancy, and everything was normal. It means this is you can see it, but I'm afraid that there are conditions where the complete one cannot be seen neither. This is not as obvious. And the condition I assumed to see before by Edwin was this one. This is the condition called scimitar syndrome, because I tried to distinguish between two conditions. The one is the small right lung, and the other one he showed was a right lung agenesis. In this condition, what you see is a heart shifted to the right, similar to the CCAM on the left side, pushing the heart to the left, to the right. But both lungs appear have a normal echogenicity. That means the likely diagnosis is this is a small right lung. And there is one cardiac condition when there is an hypoplastic right lung, very, very rarely found on the left side. There is also a isolated hypoplastic left, but the classical one is on the right side. It is called scimitar syndrome, which is a combination of I don't know if I have here the. Give me a second. No, I don't have the class. And this combination of hypoplastic right pulmonary artery and abnormal connection, mainly of the right inferior caval vein, infradiaphragmatic into the inferior vena cava. And in some conditions also a connection from the aorta to the lung as like a bronchopulmonary sequestration, some separate vessels. Now, what I learned from this case, I knew it could look like a scimitar. It may be my first scimitar, and it was my first one. And I got this plane, but to be honest, I couldn't tell you from this image if it's the liver veins coming together or if it's pulmonary vein. This is why what I learned from this case is easily turn your translucent to get a longitudinal view. And what you see here is one vein entering the inferior vena cava. And believe me, you will never be able to separate on a cross-section if it's here and there. This is why if you look at here, this is the inferior right pulmonary vein entering the inferior vena cava in a case of a scimitar syndrome. In other words, let's say the message from these 3-4 talks and images is that if you have a suspicion of an abnormal lung vein, go for a longitudinal plane, because you will see all the less infradiaphragmatic. You will see here. This is a summary. You will see the infradiaphragmatic abnormal pulmonary venous drainage. You will see the scimitar. You will see the supracardiac. The only one you cannot see is probably the one at cardiac level. But the most common one is the one going to the up, and you will follow that it's not going into the atrium, but going up. You have to do a suspicion on the fourth chamber. You have some idea the chamber, let's say the ventricles are or the atria are of different size, but you see a collecting vein in behind the atrium. But this collecting vein does not tell you anything because it can go downward, can go up, it can go to the left and to the right. And this is why if you have a suspicion, go for a longitudinal plane and use color to follow where the vessels, the veins are going in, and you can sample them, of course. Because in fetuses with breathing movements, you can see also some of these flow. So I think we have many cases, but we haven't prepared more. But you were a very nice audience. And before I finish, I would like to